Hi, this is Setri Fugar from Rush University Medical Center. I'm here with Dr. Simone.
Hi, Dan, Bensimhon, Moses Cone Hospital.
All right, we're here at ACC 2019. Dr. Simone just presented on heart failure. We're just going to ask him a few questions. All right. Dr. Bensimhon, the question we have is for fellows in training, what is the most important thing when it comes to managing stable patients with heart failure?
Yeah, I think, as fellows, there's two things you want to, well, there's a lot of things you want to do as fellows, but one is get the skills you need to practice cardiology. The other thing is it's time to learn the guidelines, right? This is what does guideline-driven therapy look like? And I think one of the things product theaters like this is to help people learn the guidelines and realize, for 25 years, ACE inhibitors and ARBs were standard of care for patients with systolic heart failure. The guidelines now say if you have systolic heart failure, replace that with Entresto. And I think that's part of what fellowship is all about, is really having time to look at the data and understand the data.
And what do you think is the keys to keeping our stable heart failure patients out of the hospital?
Well, I think that's a very tricky question. If people understood what those keys were, I think we'd take our readmission rate from 20% down to 10%. And I think it's much different for every patient of what the issues are for rehospitalization. If you look at studies, no one strategy has ever been proven to prevent readmissions. But what I think is it's a targeted strategy for these patients and optimizing their medicines. But the thing to realize is that a heart failure hospitalization is a sentinel event. 1 in 3 patients after a heart failure hospitalization will die in 1 year. So those are a high-risk patient population. It's not just, they drank too much fluid, just send them home. Take that opportunity to look into their care and optimize them.
The other question I have is, with all these new home monitoring devices, and what is your opinion on the utilization of these home monitoring devices, the CardioMEMS, and all those other devices to help guide the management of these patients?
So yeah, I think, like in every field of medicine, telehealth and more diagnostics are becoming really helpful. And it's really a matter of understanding what patient selection is. And not all patients will benefit from these devices. But patients with recurrent heart failure hospitalizations who have been tough to manage, I think there are now increasing options, whether it be CardioMEMS, the new heart failure vest, the REDS vest, where it does non-invasively measurement of fluid, provide us opportunities to really try and help these patients. Also ICM, the Medtronic's device and St. Jude's device, where you look at Optivol and things like that, also provide a whole host of information about volume status, patient activity, and arrhythmias. So there are a lot of opportunities, and I encourage people to get comfortable with 1 or 2 of those and incorporate them into their practice. All
right. And the last question for you is, do you have any tips in order for us to be able to maximize the patients? Our heart failure regimen for our patients is one of the things that's quite difficult for physicians and cardiologists, especially trying to up-titrate beta blockade, ACE inhibitors. What have you used in your practice, and what has worked for you?
So, I think, as a busy clinician, I spend most of my time seeing patients, and one of the things is time, right? You have so many patients who want to come in and see you. Finding time to bring a patient back just for medication titration can often delay the process. If you don't bring them back for 6 or 8 weeks, you can delay the process of up titration. So what we've done in our heart failure clinic is we have a heart failure pharmacist. The physician sees the patient up front and then says the next 3 or 4 visits every 2 weeks is going to occur with the heart failure pharmacist. And that person will titrate the meds and then bring them back for 2 or 3 months, and then the meds have been titrated without the physician involvement.
That's a great tip. Well, thank you very much, Dr. Bensimhon. It was a pleasure. For more videos like this, go to www.youtube.com/FITsontheGO. Thank you.